The goal tonight is really to give you effective practical tools of the right stuff. The important thing to remember is that everybody's different. Everybody needs something different. Everybody expects something different. Not saying to other friend about you and about your worth. And sometimes even your own individual worth needs something different. And kind of figuring out what's best for you for that worth, that worth. The first thing I'm going to cover is insurance. That's something that comes up a lot. So there's three types of insurance, well, two types of insurance out there today. There's Medicaid, that's the managed care plans like Zelle, Health First, United. There's private insurance, Oxford, Aetna, Cigna, some of them, and then there are some doctors that take self-pay that take cash payments. Now, the first thing to know when you're looking for a doctor in a hospital or a midwife in a hospital is the insurance. You don't want to go to a hospital or a practice that doesn't have insurance, just have to go and expect how to pay insurance. I once had a woman who told me she was so excited that she switched to a new doctor, and literally that at 38 weeks she found out the hospital she was delivering was not paying for insurance, and she was going to expect massive bill from us. So even though it's a minor thing, something that can be major, and you want to first find a provider that you're looking into, take your insurance. Okay, the next thing you want to look at is your provider's reputation. The first thing we always want to ask is word of mouth. What do your friends, family, your representative, mashpia, somebody say about this provider? If you know that 10 of your friends had great experiences with this provider and the birth plans were met, they've listened to it with her, and something similar to what you're looking for, that's a great start. Somewhere to start. We always trust our friends, people that we know, people that we trust. You can look at online reviews like forums, social media, Google. You can see what kind of ratings they have online, even though we know they're a little bit, kind of fudged, but you can definitely look at it. And the last place to look is we're very lucky in the Jewish community. We have organizations that help us with this kind of thing. So I, work for Bnei Olam, and we have Time of Crown Heights vision now that started with a helpline, 8 times all these organizations are there to help women find the right provider. So we're really lucky. I always say being part of Klal Yisrael is priceless. We have so many organizations that support us, so many people to reach out to, and we should make use of that. When you're, looking for a doctor, provider, something so personal, so private, so important, and definitely reach out. The next thing you want to look at is the provider schedule. Okay, so first of all, their numbers. How many births have they done? How many procedures of that particular procedure that you need have they done here? How many C-sections have they done that year? Right? If you say you need a special PGYN surgery, you want to go to this doctor, heard that he's really good, but he's only done it in a year, versus the doctor that might not have the best bedside manner, but he's done in a week. Whose hands would you prefer? Whose skill would you prefer? So all the doctors have their numbers published. You can ask them, and a lot of the organizations are very familiar with these doctors, know who is better at what and why. As far as C-sections go, every hospital publishes their C-section rates at the end of the year. We're going to go through some of them a little bit later. But you can also ask individual doctors how many C-sections they have done and why. The thing that you have to keep in mind is that every hospital is different. For example, a hospital in Columbia, high-risk hospital, there's a lot of high-risk patients, a lot of high-risk babies, unfortunately, 6 babies in the state. So it makes sense that a hospital like that can have a higher C-section. It makes sense that a hospital like that the doctors are gonna have a higher C-section rate because they take the higher risk cases. When you're, have to worry about a baby's life or a baby's illness, C-section falls in a different level versus a baby that's healthy and a low risk birth. But in a hospital where, it's a low risk hospital, low risk doctors, or the patient themselves is low risk, and you're not worried about anything wrong with the baby or need that specific NICU at, say, a hospital like Columbia, you want to know, what is this doctor's C-section? How many C-sections they avoided? And that's definitely something you can ask. You want to look at their education, medical school, residency, any papers they've published. Maybe they published a paper on C-section rates, or maybe they published a paper on something that's pertinent to you. All this information is available online. Definitely something to look at. And then we have some doctors who really have a specialty. There are doctors who are less have less interventions, have more patients, have a better bedside manner, have a lower C-section rate, are doctors that specialize in multiples, or doctors that specialize in IVF patients. And if that's something that you need and something that they specialize in, definitely something for you. Then you've got to look at the hospital. There's a couple of different things that you look at when you look at a hospital. So you look at the location, the facility, what the labor rooms look like, what the postpartum rooms look like, is there showers. The one story that I always tell is that, I had a mom who told me she wants to deliver in a hospital. It was very important that she gets labor in the shower. And I just told her the hospital that she wants to deliver in the shower, there are no showers. It's just like they actually redid the unit about 10 years ago, and they put the shower out. There isn't even a shower in the delivery. So you've got to you have this plan, you want to labor in the shower, you want to use this doctor, but this doctor delivers in a hospital where there's no showers. So you've got to take all of that into accountability. I do think, looking at postpartum is something you can look at, what postpartum rooms look like, what's going on, but personally, I don't believe it's the highest thing on the list. We are going to a hospital for care in this situation. We're not going to hotel on vacation. We hopefully won't be there for very long. If you want to go for a tour and look at it, that's great. But, there are other things to look at the hospital, like distance. Maybe you have quick labors and you hospital's an hour away. That's something to think about. Maybe you need something else in that hospital, but definitely something. Staffing is very important. Some hospitals, most of the hospitals in New York are teaching hospitals, but there are some hospitals that don't have residents. And for some people, that's super, super, super important. For some hospitals, their nurses find wards for their nursing. That's something that's super important to you, and that's something to think about. We are lucky we have two hospitals in Brooklyn that have doula support. My mom is a Methodist, so doula support. That's an added bonus that there's a doula on staff to support you. They also have lactation consultants. That's huge. If you're somebody who wants to focus on lactation, or lactation has been difficult for you in the past and you want extra support right from the get-go, knowing that the hospital has lactation support available to you is an added bonus. If you don't plan on hiring your own doula and you want to rely on a doula, go to a hospital that has doulas versus a hospital that have doulas, something to think about. All these things are questions that you should be asking, touching on, and discussing. And the last thing is the NICU. Now, the highest level of NICU is the regional NICU, which is like Columbia. I had a patient that could only, there were two hospitals in the entire tri-state area that she could deliver in that could take her baby's care. The baby was very sick, they needed specialty care, and the two hospitals that would even accept the baby were Columbia or CHOP in Philadelphia. So she had to choose between those two hospitals. She was local in Brooklyn, so obviously Columbia made much sense. She doesn't have insurance, but that was that from her baby's care, that was the place she had to go. There are different levels of NICU. Level 4, level 3, level 2. Level 4 is a lot of the hospitals that are just under a regional level NICU. It's the highest level that you get, besides like a regional hospital. And then there's a level 3 and level 2. As you can imagine, a level 3 is higher than a level 2, and a level 4 is higher than a level 3. So if you're having a baby a little bit early, or you know that your baby's going to need something extra, you want to consider the level of the NICU of the hospital in your choice, if that's the hospital you want to choose. So this is the one thing that everybody asks about C-section. So these are the C-section rates published by hospital. The link is on here, and I'm happy to share the PowerPoint class to consider so you can have it. These are the published rates for this past year. And as you can see, there's hospitals like Methodist Hospital, Staten Island Hospital have very, very low C-section rate. And NYU Brooklyn has a low C-section rate. Maimonides has a low C-section rate. Then you get a hospital like NYU in New York City that has a little bit of higher. Cornell has a higher C-section rate. Bearing in mind there are sicker babies in the hospital. So definitely looking at the C-section in your hospital is something to look at and consider, but always keep in mind the types of births that are happening there, the population that's going there, so that you can keep that in mind. Yeah.
Who decides the C-section? The doctor that you're with, the hospital?
It's the doctor, right? You can ask each doctor in their own way. You get also hospital.
How does that matter Treating your doctors, right?
Because every hospital has standards that they want to meet.
Okay.
And also, every hospital, not every hospital, most hospitals these days have somebody called a safety officer, where they kind of can override a doctor's decision. If they feel that this baby's not safe or this mom is not safe, they are the ones who can go and call the patient. Doesn't happen often, happens very randomly, very infrequently. I have seen it happen once or twice. Also, depending on the practice that you would, what happens if you get to the hospital there? And the covering doctor is one of the doctors from the hospital that's covering, or the residency covering. You want to get a little bit of an idea of what rates are.
And the hospital decided to let it fly. Like there are hospitals that don't allow it.
No, there's two types of doulas. Private doulas. Every hospital in New York allows. I only know one hospital in the United States. California. What? They had a very bad. It was many years ago, and that really did something that's out of the scope, and ever since then, we don't have. But in New York, everybody does, and you can always pay the hospital. Most hospitals allow 3 support people per patient. So, let's say a spouse and a doula, parent, a mother, if that's what you want. There are some hospitals since COVID that have said only 2 support people. We have gotten that, like some hospitals, I believe NYU in Long Island is still doing that. I think that's the only one that I know of that right now that's still 2 support people. But you are always allowed a doula in with you. Some hospitals, like my mom, have on staff. So if you don't have your own doula and you want some extra support at the hospital, there's doulas there.
Like, is that like on call or is that like you plan that in advance?
No, it's on everyone's on shift. That day, just like the nurses are on shift. The doulas are on shift and they help everybody on communicate with the nurses, with the charge nurse, with the doctors, see which patients need support and help them. It's really a great program. You know, some of the patients use them at early labor and you're not active yet. You would come to the hospital, you just have to travel. It's a really nice added bonus. So my monitoring program has been running for a very long time. It's actually called the State Doula, run by one woman. It's really amazing. The programming Methodist that I'm a part of started in COVID, when the governor took away support people from laboring women. The hospital started this program.
There's somebody there at like 2 a.m.
I want to say this. There's somebody there like most of the time. I can't say every hour there is somebody, but we really do try to cover it.
There's one doula per shift, right?
No, during the day there's 2, and at night there's 1.
So did you say you're part of that team?
Yes.
So if there's a hospital in private that has right now, you're getting 6. Like if you bring your own private doula, are you getting a better level of care than if you use that? Like is there an advantage to using private doula?
There's always I think there's always an advantage, especially for a first aid. You have that support at your side. You have somebody that you met beforehand. You have somebody you created a relationship with. You have somebody wanting to know you a little bit. The doula that's coming in is going to be hands-on there in the moment to try to help you. They're great. You know, a lot of the doulas that I've met over the years that my mom and maybe know well, they really do try to keep it as much as possible, but they're not going to stay in your room 12 hours straight. Your doula can stay in your room 12 hours straight. Need
And do home.
That's not good if you need and support at home. You're right. Sorry.
If you need a doula to be there for 12 hours,
Not at all.
My worked for 3 days. 3 days. My first baby was 3 days. Yes. Some people do have
your first client or
my first baby was 3 days. And there are people who have very long babies.
So I thought you meant 12 hours after. Not labor.
Labor
Also,
support.
the doula that you hire privately to your house, which especially for first baby or something who has a history of long labors, you really benefit from. And the hospital doula is
more or less. You have to divide. Correct. I think it's a great choice for like early labor, right? When you're like on a medication, like a cervical ripener that like helps it to soft, and you're kind of really sleeping, but you have some questions along the way, but you're not in active labor yet, and your private doula hasn't arrived yet. It's great to have that extra support during that time, and you're saving your doula when you really need her. So she comes in with full energy when you really need her. I think that is effective. Great support, but it's not like having a doula at your side. But you also need to see doulas, and we could do a whole session just on doulas if you want.
I want to say, I love they actually help us out.
And as a hospital doula, sometimes I get to do births with other doulas. So much fun.
Yeah.
But they're billing your insurance then? No. It's private.
It's a hospital.
That means it's private.
You're asking about the hospital
Private.
doulas?
Yeah, and the hospital,
The hospital
ones that are
doulas
here,
are
not-
paid by
We're paid by hospital.
which means that insurance gets billed. This means
No.
you.
the hospital.
They bill for services, so
So it's
give
automatic.
comfort measures, I do different things, you bill for things, but it's not like you're
The
billing
patient
for
doesn't
a
have to pay.
doula through your insurance.
Patient doesn't pay extra, basically.
No. Sorry, what?
So basically, the patient's not paying extra. for the
No, the
hospital.
patient is not paying. No. Just like you're not paying extra 3 downs or 6 downs, or you don't pay extra. 20 complex, yes, or, you're not getting the patient. I'm sorry. You can play around and I'll just give you the like that. You can play around.
Oh, go ahead. When you're born,
Oh,
an hour. Should be. When you're
so do it quickly. Do it quickly. We'll wait a second.
Recording in progress.
But you're all sure. Yeah, it should be good now. Thank you. Yeah, you could do the same thing.
Okay. Another thing to consider when choosing a provider is easier access to a provider. How does after hours work? Time of appointment? Are they only open in the morning? Are they only open in the afternoon? How does that work with your schedule? What are their evening access, their weekend access, hours full? People at 12 o'clock after special classes doing the teaching. How does that work? Everybody wants to know the doctor, they have something wrong. So that's very important for a lot of people, and it should be important for everybody that You have a way, you don't
want to access them. And additionally, you want to find out if that's virtual, if that's messaging, if it's through other staff. Are you always going to reach a nurse? Are you going to reach the midwife who's on call? Are you going to reach the doctor? And the last thing is who covers them. You know, every doctor that you pick is a human being. There's no way they live at the hospital or could be at the hospital on call 24/7 all the time. So who covers when your provider is not there? Are they part of a group? Are they part of a group of 4? Are they a part of a group of 10? Are they part of a group of 17, 18, 20 doctors? And any of those 20 doctors could be at your birth. How does it work? You want to understand this aspect about the group, the provider that you're choosing, so you know what to expect. Who delivers your baby? So we spoke a little bit about this. So your provider can't be there all the time, but what happens if he's not there? Does he have one partner? Is your philosophy aligned with him? Does he work with his partners very well? Are their philosophy the same? Are they like kind of all the same kind of style doctors and will work for you and will respect your decisions and choices? Or is there a resident who's delivering? Is it going to be like an intern, a first-year resident, or a fourth-year resident? And what are their capabilities? Is it going to be an attending from another group who's going to be with the resident? What does it mean if your doctor's not at the hospital? Who covers? You know, with the midwife also, who's covering? Is it like a floor midwife? Is it a midwife from your group? How does it work? A lot of people will choose a practice where they can feel that they will get to know all the providers. So there's 4 or 5 providers in the group. They'll get to meet all of them. So they've met all the doctors in the group. So they know that one of those 4 or 5 doctors are they going to be there at their delivery. Sometimes people want to go to some of the midwife groups that we have because the midwives are always in the hospital. That is like, for some people, the most important thing, that you're going to a hospital and the person who's going to be seeing you right away when you get there is going to be somebody from your group, not a resident that you've never met who kind of covers for the doctor till your labor is more active and the doctor actually comes in. A little bit more style, a little bit more midwifery care, which I know that Chaya Musia and Nechama are going to go into a little bit more detail, but the idea of having like a midwife is really somebody who's like at your side throughout this whole thing, not just who comes in just to deliver, which some doctors do. But for some patients, that's okay. You want to be managed by anybody, by a resident or anybody else on the floor, on the unit, and you're okay as long as your doctor is there for the end. These are all things that are very personal and different for everybody. And you have to think about what's important for you and what's important for that pregnancy, for that baby, to be able to make a decision on which type of provider you want.
Are you saying that when you choose your provider, you need to choose a doctor or you can choose a midwife?
It could be either or. Provider means doctor or midwife. Yeah. Yeah.
And like, when would you get a resident? If your doctor wasn't there, so when's that going to happen?
So not necessarily. So I mean, yes and no. So if your doctor's not there, yes, you will get a resident. You have to remember, residents are there to learn. Okay, they have to learn, right? Can you what? Yes.
Yes, you can always, yeah, you can. Doctor in training.
So you first of all, you don't. Okay, so first of all, you don't want to get on the negative. Guys, you don't want to get on the bad side of anybody when you're in the hospital. The last thing you want to do is be yelling at staff, because then the whole floor is going to talk about you. The nurses, the doctors, everybody. But you can turn around to them and say, I would like an attending only. The resident could stay in the room so they could learn. They could watch.
They can watch, but put their hands to their side.
Yeah, like
the best way to state your need is very like flat tone. Thank you so much. I would love to have an attending resident. You can stay in the room, but please keep your hands to your side. And you can just say it again. When you start saying, I asked if you could put your hands to your side. Thank you. I asked you to put your hands to your side. And you could just repeat. Robotic, very, and it works.
Of course it's a choice.
Everything's a choice.
You know, a few weeks ago I was in the hospital and there were a bunch of nursing students and they weren't getting to see any births. So I went up to one of them and she asked me, like we were talking, she asked me, she's like, what am I going to do? I said to her, well, have you ever like introduced yourself to the patients? She's like, no, I'm just walking with the doctor when they're ready for delivery and then they ask me to leave. I'm like, but maybe if you walk into the room, like when the woman is not in pain and not pushing and not in, and you introduce yourself, you offer to bring her a hot pack and a cup of water, and then you say to her, would you mind if I watch your birth? It's a very different picture. Would you mind if I hold your leg? Can I help you during your birth? You know what? She got to see a lot of births at the end of her shift. It's really
You also have the right to say no
Right.
to all of the above, by the way.
correct.
And if you don't like your nurse, you can ask for the head nurse or for one of the doulas, or if so you don't have, or your midwife or your doctor or someone else, obviously always more comfortable, and say, I'm not so comfortable with my nurse, can I get somebody else? No problem. I don't want any residents or students in the room. We get this all the time.
Like I asked for my doctor and I don't know why he didn't show up.
Well, I don't know. I don't know that particular. I don't know that particular situation, but that's why it's important to ask your doctors what happens if they're not there. It's impossible for them to be there, right? Every single minute. Excuse me, of every single day. Okay. Or maybe he was in the OR. Maybe I don't know that particular situation, but you're entitled to ask. You are entitled to ask.
Attending
As a
doctor
regular.
is the doctor. Yeah.
Yeah, or your doctor is also considered an attending. That's the level. But really, and that's something to discuss with your doctor. Like, will you be there for my birth? Like, if you're not there, who's going to be there? Who's going to be covering? Do you allow residents to come with you? Sometimes the doctors will say to the patient, I'm going to be here for the delivery. Do you mind if a resident comes in to watch? Like, sometimes I'll see the residents deliver. I had a patient a couple of weeks ago. She was fine with the resident, but she was scared for the resident to stitch her. So she said to the doctor straight, I'm okay if the the resident delivers the baby because you're standing right next to the resident, but I don't want the resident to do any stitches. And the doctor was like, okay, no problem. That was her choice. It's absolutely your choice, 100%. Just do it in a very firm but respectful choice of words way. That's what I tell people. You don't want to throw anybody under the bus. You don't want to put people down. You want to just stay respectful but firm. Yeah.
So I had a question on the previous slide. You said something about philosophy being aligned with the doctor. Can you elaborate more on that?
Sure. We're going to talk a little bit about it now, but a lot of it is if you
it's on this one too. I didn't know.
yeah. If you want, for example, if you're the type of person who's looking for a VBAC, which is a vaginal birth after cesarean, you had a C-section for some reason, and now you want to have a vaginal birth. If you go to a doctor his philosophy is not to get you that vaginal birth. Philosophy is not I'm going to do whatever I can to get that vaginal birth, and you're on different pages. That doesn't help you.
Why would he not want to do vaginal birth?
It's much easier to do a repeat C-section.
Why would they do it? You don't do C-section unless it's absolutely necessary.
That's what we would like to see.
That's what we would like to see and believe, but not every doctor.
Or else you make a woman endure that again.
Is it true after one C-section there's more risk?
Yes.
Yes.
So that is the reason there are additional risks to doing a vaginal birth after a C-section. There are also risks to repeat C-sections. And it's a personal preference thing, or how you look at the statistics, or which risk you're more comfortable with. There are many doctors who will say they prefer just doing another C-section.
So once you have one, you do to just have a C-section?
No, you never do.
You find a provider that will work with you.
Yeah,
and that is what we call VBAC supportive, not just tolerant of maybe trying if everything aligns.
Right.
And you're never doomed. If someone needs to have a repeat C-section and they have C-section for all their kids, you're not doomed. It's a different passage to having a mother.
Sorry?
Is it ever not possible?
Sometimes. Sometimes it's not possible. There's hundreds of different scenarios that can come up, but sometimes it's not possible. We always say, healthy mother, healthy baby, vaginal delivery. That's our goal, right? Correct. I had a patient a couple of months ago, came into the hospital, and right away in triage, which is the area where they assess where your labor is up to, her baby's heart rate was in really bad shape. And we were flipping her in all different positions to try to change her position to see if that would help the heart rate, and nothing worked. She was with a fantastic midwife. We tried everything, absolutely everything to help her. We even took her off a monitor, moved her into a room to give her a walk around a little bit, give her some extra time, see what happened. We got into the room, the baby was even in worse shape. And we had to go emergency to the OR do like an emergency C-section. Now, in that moment, like we had to like, you know, turn to her and tell her, you know, like you have to be that tough, strong mom right now to do this for your baby because your baby is in danger. We have to do this. We don't have a choice. Like sometimes, you know, I mean, obviously she always has a choice. She can say, I don't want to do this for my baby, but she was like, okay, get my baby out. Please make sure my baby's healthy. And that's what we did for her. You know, they did an emergency C-section and thank God her baby is healthy and she's healthy, but it was also a lot. It was traumatic. It was the opposite of what her birth plan was. She was using a midwife and, you know, and that, Baruch Hashem, glad to hear. So, you know, there are lots of different scenarios that can come out. But if you specifically are looking for a VBAC, you really want to have a doctor who's in line with that philosophy and really wants to support you through that. Not just that they're tolerant of it, but like they really support you through that process. Another example, yeah.
Can you talk about the difference between having a midwife and doctor?
We didn't go into details of Dr. Midwife yet. We spoke more about how to choose a provider, what's important, what to look at in each provider, whether it's a midwife or a doctor. We are going to go into some things. Another thing to look at is pain management, right? Are you the type of person who's going to take childbirth classes? You're really going to be able to manage, your pain tolerance is excellent, and you are going to want to take an epidural. You're not going to take an epidural. If your doctor is the type of doctor is like, all my patients get epidurals, like you guys are not on the same page. If your doctor is the type of person who says, none of my patients take epidural and you want an epidural, you're not on the same page. There are different pain management tools like nitrous oxide or saline injections or using the bath or the shower to help you through the pain. But all of those things that you have to find out if a hospital offers it. There's only 2 hospitals, I think, in New York that offer nitrous oxide. Very few hospitals offer the saline injections, and a shower is something that a lot of hospitals offer, but not all hospitals have working showers.
What is it? What is nitrous?
It's a gas that they give you through a mask. That are we asking talking to different things? Sorry.
Yeah. So she finished with this and we'll get to you. Go ahead.
Only 2 hospitals that I know of have nitrous oxide. It's a gas, like you use a mask to take it and it helps dull the pain, but it runs through the body very quickly. It kind of comes and goes very, very quickly. So you don't have to be like in a bed on an epidural and numb completely. It's just something that you can use to help you with the pain, and it gets you through the labor. Maimonides has it, and Loma, Lower Manhattan, New York Presbyterian.
You've done the laughing gas for
Like a dentist.
dentists, the same thing.
And it lasts, like.
No, you have to keep on puffing.
You have to keep on puffing.
Self-administered.
What was your question? Birthing tubs? I don't know any hospitals in New York that have them. No, nobody in New York has them.
We used to.
Yeah, New Jersey, Hackensack has one in every room. It's a private hospital. They don't have residents either. They don't take any Medicaid, only private insurance. Like, they do have it. In New York, I don't know anybody who has it, but a lot of hospitals, like for example, Methodist Hospital has showers in every room. And the other thing that's great about Methodist Hospital is that they have wireless waterproof monitors. So even if your baby has to be on the monitor, you could still be hanging out in the shower. You don't have to be going in the shower and then coming back out to get monitored and then going back into the shower and then that's a huge advantage. But most of the bigger hospitals have showers. The other thing that you also want to look at is natural alternative ways or things that your doctor will do to help you get into labor. Are they for acupuncture or reflexology? Will they do a membrane sweep for you, which is where they kind of try to separate the uterine muscle from the bag of waters to kind of kickstart labor? Well, there's some doctor's office who will insert something called a Foley balloon, which is a balloon that they put inside your cervix and they fill it with saline, and then there's another balloon that sits outside the cervix and it puts pressure onto the cervix to try to kickstart labor or soften the cervix. They'll do it for you in the doctor's office and then send you home, and you don't have to spend all that time in the hospital. You want to know what page your doctor is on. Do you have personal preferences about specific things in labor, and are they on the same page as you? Will they do this for you, or won't they do this for you? What are their policies? So that you want to try to have your philosophy as aligned as possible. Am I finished? Am I not working? I think that's not. That's so weird that it's not working. Okay. So again, talking about being aligned, you want to know, like, is your personal space, this is a very personal space for you. It's private, vulnerable. You want a doctor that will put you at ease, somebody that you can ask anything. Are they respectful of your religion? Are they respectful of your birth plan? Do you feel heard? Do you feel respected? These are all the types of things that you want to discuss with your provider, that you want to, whether it's your midwife or your doctor, to know that they are on the same page as you. Almost not working. There we go. So this is, I'm not going to talk very long on this because I really do believe every woman deserves a doula. I really believe everyone should have somebody at their side, even if that person is your mother acting as a doula or your sister acting as a doula. I don't believe anybody should ever go to the hospital alone. Nobody should ever be there alone. But you know, you want to make sure again that that you interview them, that they have the same philosophy as you, that they're available, that they have good coverage if they're not available for some reason. They could have two births at the same time. They could have family, something going on, or an emergency, chas v'shalom. You want to make sure that you are understanding, their understanding of you, and that you're on the same page. And whether you decide to, you know, have a private doula or hire somebody through insurance or, you know, just use the hospital doula staff is your prerogative. But think about all those different options and what they mean and how it changes the support that you get during birth.
Through insurance, is there a way to choose?
Through insurance, there are some doulas that take insurance and some doulas that don't take insurance. So you can get the list from your insurance of who takes, like say you're on Fidelis, you can get.
From like people in Carnegie that
Yes.
both insurance and a private thing.
Not always.
I always thought that doula was something that like had to always pay for in pocket. I had no idea that
Insurance is new.
Oh, it's new that this year?
It's new. Just like, I don't know if anybody heard that Medicaid is also starting to cover dinners, food for people who are pregnant and postpartum. What? Yes. Like food.
For like a year.
No, you don't get a private chef to make food for you. No. There's a set menu that they have, and they will be delivering it to your house twice a week. You don't get kosher, but you don't get to choose and decide on the menu or anything like that. It's like set. During pregnancy and for the first year postpartum, yeah, on Medicaid, yes.
It's called nourishcrownheights.org.
Correct. I can share it with you guys so you can share it.
So it's like a certain amount that they give towards.
Yeah, it's a new program that they started. The one in Crown Heights is being run under the UJO from Williamsburg, but it's done by a Crown Heights caterer, so it's all under the CHK. The last thing I put in here was just a flyer that a couple of us made on postpartum anxiety, postpartum psychosis, postpartum depression, and the differences between each one with emergency contacts, should anybody need them. You know, Chaim of Crown Heights does a lot of work on this. We have a lot of referrals that we're able to do, and we're here for women in any way that they need. But I also just wanted to put some information in here so that you guys have it, should you need it for yourselves or to share with a friend. And I'll send you the PowerPoint so that you guys can share it with everybody. I'm going to send the PowerPoint on the group, okay?
Thank you. All right. Hi, I'm Baruch.
I am Nechama and Yaffee. And we're going to talk on safety. We're going to share a mic.
We're going to share a mic, I think. I'm going to just stick it on my arm here. It's like a clip-on thing. Hope the sound is coming
It's going to
out.
hear your heartbeat.
Hmm? Yeah. So.
No, this
we'll-
one.
The computer that's meeting, but that's there. All right, so we're both doulas who attend both home and hospital births. So the goal of today's talk is not to discuss the safety of home birth or what home birth is like. We're going to go off we both attend home births because we believe it is a safe option. There's many statistics and articles that talk about why and how home birth is safe for women who are low risk. And we love attending home births. We prepared our talk together, but we're just gonna like bounce off of each other and share ideas, take turns a little bit. So there's some papers and pens laying around, and what we're going to talk about is how to choose your home birth midwife. Very specifically, home birth midwife. You can take a piece of paper and a pen, and I'd like you to take a moment, and if you're watching home from, on Zoom, you could do the same thing, and write down what are your values about birth? What do you believe about birth?
And this doesn't just apply to home birth, it applies to all your births.
Yeah, it's irrelevant of whether you've given birth before, you don't have to know anything about birth actually to have a belief about birth or have some values about birth. It's also never too early to learn about birth, which is so amazing why Michal does so much like birth education. I know that it is our, minhag not to talk about it in the early pregnancy stages. Of course, if you have a question that is relevant to choosing your provider or things like that, or you have a question about how you're feeling or whatever, of course you're allowed to discuss it with whoever you need to discuss it. But never too early to start. And I also want to take a moment to recognize that we do have some women here who gave birth and that birth is not always simple or straightforward. So if you had, a great experience or a more difficult experience, we're, also here to recognize that and support you in that way. So some examples of beliefs or values that may have could be something like, oh, my doctor knows best, or midwives know best. Another idea for a belief could be birth is a normal, natural event. Another belief could be anything can happen at birth, better be prepared for an emergency just in case. Anybody want to share what they wrote down? All right. Yeah, sure.
Try to have like as little intervention as necessary.
Okay. Anybody else want to share what their beliefs?
Like letting your body do. You mean like medications that are going to do?
Yeah, medications or anything that's done in the labor process.
She's talking about following her body's lead, right?
I guess it goes along with it.
Yeah, so these things are very personal. It's my personal belief. Let's say that, I would want my body to take the lead at my birth, Huh? What does that look like? That's a really good question. I think that's something that you're going to see covered in like a childbirth education class, books on childbirth. So if it's okay, I'm going to skip that question. It's a very good question though, and I encourage you to look into that.
Who offers childbirth education? Because I took with someone, she moved away.
Who offers childbirth education? I'm happy to.
Please do.
I do sometimes privately. Irit has at the Motherhood Center they have. Sarah Eichler is teaching like a hypnosis type. There's some things online. There's a lot of different options when it comes to that. Okay, so now that we have, I hope you all did take a moment to write down some of what your personal, doesn't have to be a general truth. It's very individual. What do I believe about birth? Now our question now becomes, how do I make sure that my provider, my midwife that I'm going to hire is in line with those values? So that's really what we're discussing here, because whatever research you're going to do, if you have this written down for yourself, now use that. whenever, the opportunity arises that you're looking for a provider, because you can always hold that against the provider that's in front of you, or the choice that you want to make. Is that in line with my values, with what I believe about birth, or is it not? Sorry? It's like dating. Yes, exactly. Okay, so what I want to talk about a little bit is what some of the differences between home and hospital birth, which make choosing a provider, I guess we'll switch over to midwife, because home births are generally attended by midwives. I've heard here and there that there's a doctor that attends a midwife, and not in New York. So there are some differences which make choosing your midwife when you're giving birth at home very important. Okay, one of them is that, unlike what we discussed before about when you don't like your nurse, or you don't like, your doctor, or you don't like your midwife and you're going to ask for somebody else, at home, it's not very easy to do that at all. You hired your midwife or you hired your team, and if during the birth it turns out that this is really not a good fit, well, she's the one that's there taking care of you. So what are you going to do? Sometimes when you have a home birth midwifery group that it's a group. So here it could be that you have the option, even possibly in advance of your birth, to say, well, I want this particular midwife, and then definitely as part of your interview process, ask, is that something that could be an option if they're, for whatever reason, have a certain preference or a certain midwife I don't like. And also, if in birth it happens that it's not working out between us, can I request somebody else? Will you honor that? But typically it's complicated. Now, if you're really feeling unsafe, it's turning out that she's not skilled, or you're just feeling so uncomfortable on a personal level, which interestingly enough definitely does have physical impacts on how your birth goes, as well as could have an impact on different decisions that you might make, and you're just not feeling safe with this person, yes, consider firing her. Sometimes you can hire a midwife on the spot. You might need to pay her, separately, privately, or you can consider transferring to a hospital, instead.
Because like even in a hospital, like I don't get how you could just, you don't like your doctor, how you just.
It is definitely very complicated. Sometimes there's a team, so you can ask for somebody else on the team, or you can ask for a resident. It's definitely sticky. I feel like Irit would probably be better in answering this question. You don't like your doctor on the spot. Do you have an option of asking a resident to deliver you? You can. Ask for a resident or somebody else who's on the floor.
If in a situation where you don't, right, but if you're in a situation where you feel like the doctor is not in a healthy state and it's not a healthy situation for yourself, I would want to go and switch.
But it's already, let's say by the pushing.
You can say, excuse me, could you step out? I would like somebody else. You could just say straight like that. You don't feel safe, and you don't feel like he's being safe. You can say, I don't feel safe with you. Can you please step out and send in another doctor, an attendant, or a resident?
I will say, because I think we're getting this question in different forms already a few times, you're the patient, you're the birthing woman, you're paying them. Whether you're paying them directly or your insurance is paying for you, they're being paid to service you. It's your birth, it's your body, you get to decide. You have rights. These are official rights also. These are legal rights. You have a right to be cared for by someone that you feel comfortable with. Yeah, don't hesitate. If you're
saying like not to start it on a bad food, how could you say this nicely?
Very
like that.
Very monotone.
Very firm. That's use your choice of wording.
I don't feel safe. I would like to fire my doctor. I would like another doctor.
And sometimes when you have somebody else in the room, whether it's the nurse or your doula or your mother, that could be helpful, or your husband. Husbands are very, very significant in these kind of situations because they have a certain legal representation, more even than a doula. The best is when mom speaks up for herself, husband is next.
Safe for differences of opinion. I mean, it's like you're saying that value thing. Like he wants me to break my water and I don't want to. I don't know. Like not like that.
I don't remember the author's name, but there's a book called A Natural Hospital Birth, or How to Obtain a Natural Hospital Birth. I don't remember the author offhand, but it's a book that I often give to my clients to read, and those of them who are living in the hospital. And one of the things that she says repeatedly in that book is to always ask for extra time. I want to break the water. Can I think about it for an hour? Please give me an hour. Nobody will ever say no to giving you extra time unless it's an emergency and a decision has been made on the spot. But in a situation like that, if you don't know how to say, like, I don't agree with my doctor.
Those are frustrating, but that's.
Okay, that's another, we could do a whole talk on just doulas if you want. We could do a
We're
whole-
gonna get into also like what questions to ask, and the same as when you hire your
Hire
doula.
doula.
Ask those questions. Like I've had people ask me straight up, are you going to, are you gonna let me have an epidural? For starters, I have a hard time with that wording because I don't get to let you or not let you, neither does your doctor or midwife. You decide, and it's up to me as a doula to support you. But if that's something that you want to know about, yeah, definitely ask. What's your philosophy?
You two are doing that.
We're all doulas,
Yeah.
all three of us.
So why did you say that she would be more qualified to answer that question? Like, what's the difference?
I don't do home births. I do only hospital. She was
And you
asking
do both.
specific.
We do both.
Yeah.
Go ahead.
So before we got on the tangent, so you were saying for a home birth, you have the choice, if a professional person is not reached out, I didn't realize, you can choose to go transfer us.
Yes.
Yes.
Will you automatically have a present?
Not necessarily.
You don't
You,
have someone in.
so sometimes your doula will have a connection to another doula, to a provider. And sometimes, well, if you're being transferred by your midwife might have a connection to the hospital and you might not get a resident.
But usually what they would rent, like.
Yes.
Likely.
The straight up, you don't make any plans, you're going to be cared for by residents.
Yeah.
That still also means that you also have the right to say, I want to be cared for by a doctor. You might have to keep on asking. The doctor might indeed not be available. He might be in the middle of a C-section.
I want to tell you, I once walked into a hospital and the mom's preference was females only. And a male doctor walked in and he says, I'm here to check you. And I said, she wants female only. And they said, there's nobody available. I said, that's okay, we'll wait. And 2 minutes later, a female doctor appeared. It's okay, you're allowed to wait. It's not an emergency to be
You won't
checked.
like brush off what you say and think you're being ridiculous or so.
Sometimes, but just
It is their job in the hospital to
move
care
things along.
for you in the way that you want to be cared for. That is acceptable practice. So if you don't want a male nurse, for example, it's very normal to ask for a female nurse.
Like a male nurse, like offering to tell me how to breastfeed.
By the way, the men might be more competent.
Yes,
Qualified or.
you might want a male.
Just saying.
It's your preference. It's what you feel comfortable.
Right. But none of your requests will be like belittled or like, they won't think you're being silly or. It might be.
It's okay. It's okay.
It's their job to be professional about it. It's our job, or it's as a, guest, patient, mother, your job to be as, polite about it as possible. It's their job to swallow the insult and be professional about it and say, sure, I'll be right back.
It's kind of like if your dish comes in the restaurant, not the way you ordered it, you have the right to send it back to the kitchen.
Exactly.
Same idea, right?
Is the chef going to not like it? Maybe. All right. Okay, so we're talking about why home birth midwife choosing is in some ways more important than, in a hospital. One of the reasons is that in a hospital, there's a lot of people walking around on the floor, residents, doctors, specialists, whatever. If you have a midwife and you're in a hospital and it's her second year as a midwife, let's say, and there's something that she's having a hard time with, or she's not sure about, or this woman needs some stitching, but it's just a little bit more complex. There's somebody down, or there's an emergency suddenly. 5 people can come running in, or she can call the doctor or other midwife of her choice, and somebody will come in and give a second opinion, give an extra pair of hands. At a home birth, you don't have that option. It's your midwife, and in most practices, they also bring a home birth assistant who has certain trainings to do certain things. So yeah, you really want to make sure that you have a midwife that you chose that you feel really is the right fit for you. I'm going to talk a little bit about hiring different types of, not all home birth midwives are alike in many different ways. We see midwives doing home births that are copying a little bit more the hospital or the medical model of care, and we see home birth midwives that are doing a more holistic type of care, and of course you're going to have everything in between. So I'll touch upon briefly what I was also asked during Irit's talk. In general, the medical model of care versus the midwifery model of care. In general, the belief in the midwifery model of care is that birth is a normal, natural event, which should just progress normally, just like anything else that our body was made to do, and that we're there in case something goes wrong and that we need to intervene with. That's typically the midwifery model of care. The medical model of care usually is done by doctors, so they went through medical school. Their training is in what is doctors, but when you go to the doctor and you have a problem, what are you there for? You're there for him to find out what the problem is. So their general outlook towards birth is more about making sure that there's no problems, finding them, treating them, taking care of them, and hopefully everything goes fine. You're going to have doctors who are in their philosophy more in the midwifery model of care, and you're going to have midwives who their beliefs align more with the medical model of care. And you have to understand that when you're choosing a midwifery practice or a midwife that works in a hospital, she's working in a medical model of care, which basically means something as simple as, do we need to get labor going a little faster, or do we need to be induced? We're not using acupuncture, reflexology. She can recommend those things to be done outside of the hospital. If you're already there and your labor stopped, you can't really leave and go get a reflexology done. So you're kind of limited in the medical model of care for many different things. And also they're bound by whatever policies are set by the hospital, by the insurance agencies and things like that. So that does influence the type of care that they give when they're working in a hospital system. Of course, you do have also midwives that are working in a hospital, but there may be home birth midwives at heart. They might give birth themselves at home, or their personal belief philosophy is very much just let birth do its own thing, because it's Hashem's wisdom, and we don't need to get involved. Okay, so that's in general on the medical versus midwifery model. Some things that we might see in the home birth that are kind of mirroring on that is in the more holistic model, and there's really nothing per se, holistic can mean a lot of different things for different people. Some people it means no venison at all. Some people it means, that I'm fully involved and aware of the pros and cons of different things, and we make joint decisions. That's typically what most people are looking for in the home birth holistic model. And sometimes when we see a midwife at home that's providing a more medical model of care, is she's requiring you to do a sonogram, or at least one, or maybe even two. She wants the 20-week scan, and she wants you to do the one sonogram before in the 9th month to make sure the baby's head down, or things like that. In the holistic model, she might not require that at all. Doing vaginal exams, either, usually during labor. The holistic model, vaginal exams are not required for a birth to go, smooth and straightforward. Something that we might see is that a midwife might say, oh, you can only go into the birth pool from, when I come, or from when you're X amount of centimeters in labor. The holistic model will say you go in the pool whenever you want. Or we see sometimes midwives that have a bit more of a medical model. They'll say, okay, once you reach 42 weeks, you're transferred out of my care, which means she can no longer be your midwife and you have to go to the hospital to give birth. In the holistic model, there's a conversation about the risks of going overdue, more than 41 weeks, 42, 43, et cetera. And the woman gets to choose which, risk level she's comfortable with and what she wants to do about these things.
So we're talking about hiring. So she said, collect your questions. Everybody has different ideas what works for them. What works for your sister may not work for you. So I'm going to jump right into asking references. You might want to ask your sister, your mother. Great, but you have to make sure does your values align with your sister and your mother, just like we spoke about. We may have different ideas, or we might have a different labor. My sister, she always gives birth on her due date, so she doesn't mind hiring a midwife that will transfer out at 42 weeks. I give birth at 44 weeks, so I need a midwife who is flexible and will go all the way with me. It's important to have your list of questions, sit down and have a consultation with your midwife ahead of time. Good idea to have a consultation with your husband and have a run through, ask all your questions. See how they answer you, see if it's a conversation, feel if they're answering you and they're talking over you. That's like something important. You never want to be talked down to. You want to have a conversation. Sure.
At what point is it at what point do you move to private provider? Because there's at certain points I'll say it's too late.
Okay. So with home birth, the fun thing about home birth is the second you're pregnant, you better find a provider. That does not mean if you found a provider that does not align with you, that you may not find another provider who will take a late transfer. But that's the fun part about home birth.
Why is that?
Why is that? We're very popular.
Not because you need to know what's going on from the beginning.
No. Not only that, they may not see you until 12 weeks anyways, like most, they're not like that. They usually see you before. What do they see you?
Yeah, around 10 to 12 weeks.
Depends on the group. A lot of OBGYNs who are single providers, you need to get in early, before 12 weeks. Some of it's even 12 weeks.
What do you mean
Even
single?
if you,
They're the only doctor. It's not a group.
they practice by themselves, you generally want to at least have your appointment booked for somewhere between 8 and 12 weeks. A lot of those groups won't even take anybody new after 16 weeks.
You should wait that long to see
Because, let me finish and I'll explain, okay? Most people see the provider the first time somewhere between 8 and 12 weeks. You generally don't see anybody before that. You need to, you can. But people who are single providers, that are the only providers in their practice, can only take on a certain amount of births. So they cap the amount of births they take on per month. So they won't take people who are late transfers and people that are coming in late because they have a maximum they can physically manage per month. Doctors that are part of a group where it doesn't matter if it's 4 people delivering today or 5 people delivering today because everyone's on call is covering the floor and somebody else is in the office and somebody else is in the second office. So it's a bigger group. There's more leverage. There's more space. There's more leverage. They could take later transfers. The general rule is basically up until 20 weeks, you can find a provider. After 20 weeks, you very often need help to get into a different provider.
Is that across the board?
For hospital midwives, yes.
Mm-hmm.
So the same.
20 weeks is kind of the cutoff. Some of the high-risk groups will say 16 weeks because they just won't take more people after that.
Right.
If I do a private practice, private practice, you said, right?
Single
practice.
Solo practitioner or single, yeah.
That would be that they would be the ones that live here.
There's very few of those left. Very few of those practices left. They're called the old school. They have smaller practices. There are pros and cons to it. For example, if you're with a solo practitioner and you go to your appointment at 9 o'clock and at 9:05 he gets a call that somebody's in labor, you're sitting in the waiting room and he's walking out the door, and you can choose to reschedule your appointment, or you can choose to wait 3 hours or 4 hours.
Do they sometimes have like a nurse or something?
Sometimes they do. Most practices have nurses, sometimes they have a nurse practitioner or PA who works with them. But if you're going to a solo practitioner because you want to see that doctor during the pregnancy and you want him to deliver you, it comes with those cons. And, some people don't have 3 to 4 hours a day to go to the doctor because you want that doctor to deliver you. That's something, to think about. But for some people, the fact that they see him in the office and know that he's going to deliver them is something that they want.
So you said you don't, what's like, from when someone finds out they're pregnant, they're not going to see a doctor until 8 or 12 weeks?
Usually the first appointment is 8 to 12 weeks, yes. So it's between
Is there
8.
things you need to know in the first 2 months of like what to eat or vitamins you should take or what you should do or anything like that?
So by collar classes.
Yeah.
I was gonna say color classes, yeah, a lot of times cover that.
Any of those things that you should be doing, you should really be doing from the time you get engaged.
When you're pregnant, a lot of times you're sick and you can't swallow all those vitamins that are so good for you. So getting healthy beforehand is a good idea.
Cheerios and milk.
Or potato
Toast.
chips. Potato chips.
Whatever goes down to keep you alive.
Just to make sure everything's like, okay?
Well, you could go to a regular doctor for a blood test to check.
Right.
Usually at that stage, there's very little they can do either way. And it also is the stage where most miscarriages happen, if they happen, and they can usually not be stopped. Usually when there's a miscarriage that early on, it's because there's something in development that didn't go right. And yeah, the doctors,
It doesn't really make sense to go see a doctor.
you don't need to see a doctor. No. Obviously, if there's bleeding or whatever, you should reach out and see somebody.
Is it recommended ever for someone, like before they get married, to see someone?
So I generally recommend, this is my philosophy, everybody can say something different. I generally recommend it's very good to establish care by a provider, either as a single adult or when you get engaged at some point, so that you have a doctor to turn to call to if something does happen before you've chosen. Even if you're not going to choose that doctor for your birth, but you have somebody to refer to for care. Going to a doctor as a woman, as a young adult, or when you're engaged, to establish care, to get a history on file, even to take a baseline set of labs, so that there's something there if you ever need to compare it to something. There's something. Yeah, an OBGYN. You don't necessarily need to consent to a pelvic exam if you don't want to at that stage, but you have some medical care. You've established care by that doctor. Getting new patient appointments is not so simple these days. There's a major shortage of doctors, major shortage of even home birth providers. There's a shortage of midwives, shortage of practitioners in general in all fields of medicine today. So calling and saying, hi, I'm 6 weeks pregnant, I want an appointment tomorrow, is not going to happen. But if you are already going for an annual PAP, or you've been there twice because you've established care, you're not considered a new patient, that time to talk about when you're coming in for your first pregnancy appointment and they have to take a whole history on that. When did you start your periods? How long were your periods? It takes up so much more time. If you've gotten some of that stuff out of the way in the history, in an earlier appointment, the provided that you're seeing that they can focus on the here and now and what's going on now. It doesn't have to do all of that. So establishing care at a provider, I think, is important and helpful.
Also, if you, for example, move out of state or whatever, you're going to a new place, I think particular if you're looking for someone like a home birth midwife, irrelevant of whether you're pregnant or not, start putting feelers out, get some information on how to choose.
So yeah, the second you're pregnant. The second I was pregnant with my first, I called and she said, I'll call you right back. And she called me back. I'm so sorry, I'm booked. That's really how it went. So, you could reference your mother, your friends. Your friends don't have to, you don't have to tell them you're pregnant. There's a whole thing not to tell before 3 months. If it comes to important things like this, finding a doula, finding a midwife, you can ask your questions and they can decide what they want. If you're pregnant or, it's up to them. Let them, but, ask questions, ask your references questions. Who'd you use? What'd you like about them? What happened? Your birth you liked, what didn't you like, would you use them again? Because sometimes you'll say, yeah, everything went okay, it was great. It was a straightforward birth, the midwife came in and caught, nothing else happened. But would you use them again? Well, when I called them the first time, they said they'll come soon. And then when I called them again, they said they're on their way. And they came 2 seconds before they caught. So I don't know if I would want to use them again. I have to think about that. So sometimes asking that question, will you use them again, makes them pause and say, and then it gives you more information. You can also ask a doula. Doulas get to see lots of different births. They don't just see the straightforward births. They see some births that might have like a few bumps in the road. Most births are straightforward, don't need any interventions. But for the ones who do, you want to be able to find one that has skills, your basic skills. You want to ask your midwife what's their strengths, what their weaknesses, what their training is, how many births they attended, have they worked in a hospital, are they only out of what made them become a home birth midwife. It's also a good idea to know what's typical in hospital, what's typical in home birth, and compare what feels right to you.
Just adding on to that, home birth midwives need to be trained in the exact same things that hospital midwives are trained in. Such as stitching, putting in an IV, placing a catheter. There is one big difference though, and that is that home birth midwives, because they're attending a very low risk clientele where most people choosing a home birth want the holistic model, so they don't want vaginal exams, they are not having an IV placed, et cetera, and most births in a low risk setting do not need any of those things. So their practice is much, much less frequent. A hospital midwife on a shift is doing 1 to 3 births in a shift. Does that make sense? A home birth midwife might be doing 1 to 6 births a month, depending if she's working by herself or in a group and how many births they do. So a midwife that's worked in a hospital for a year or a midwife that's worked in home birth for a year is not at all the same amount of births that she's done. So in terms of skills, they also need to be practicing very regularly outside of their actual work setting to maintain those skills of placing an IV, dealing with a shoulder dystocia when the shoulders get stuck, a surprise breech, and different things like that. They need to be doing a lot of hands-on practice outside, and you want to make sure when you hire a home birth midwife specifically that she's, how is she upkeeping those skills?
Trigger your questions.
Yeah, so we wrote down a couple, we have a list that was put together by Malky Schwartz, who's also a home birth doula. It is very, very extensive. It's more for the person who is interested in doing research and seeing it's for several pages long. If anybody wants to, give me their email, I'm happy to send it out after. But we're going to bring up some of the main things that we felt were most important to highlight that you should really find out about your home birth midwife before hiring her.
So, like I said, how many years have you been a midwife? One thing you want to know, and you would also like to know, has she worked in a hospital? That would be good because then she's done quite a few stitching, quite a few IVs, quite a few catheter, and maybe even had to remove a placenta or two when a placenta didn't want to come out. Where did she get her training? It's, what else do you want to jump in and say? Training and qualifications. Who's your backup? Can I choose a different backup? This is a good question because there's sometimes a midwife will share an office with another midwife and you may not like that other midwife. You can say, who's your backup? I'm not so comfortable with her. Can I choose so-and-so as my backup? And she might say yes, or she might say, what about so-and-so? I work well with her. How does that feel to you? Have a conversation flow is good. And
You can have a conversation with the backup too. So, the same way that we said in the beginning, like have a consultation in the beginning. That could be first that you're going to call, let's say 4 or 5 different midwives. Are they even available for your date? Ask them some general questions. And then I would narrow it down, once you have all your questions answered, narrow it down maybe to 2 that you're going to actually meet in person. Okay, now you've you've met your home birth midwife. You can do a consultation or, just like a phone interview with that backup midwife just in case.
And how, you want to ask your main midwife, how often does your clients end up with a backup? That's another good question to ask. If your midwife group is from, you want to find out who's on call over Yontif and how many clients are due over Yontif. You want to know what the ratio. Make sure you have somebody there. Another good question is to ask, have you ever lost a mom or a baby? Was there any bad outcome and what was the circumstance? Have you ever transferred a mom or baby to the hospital? Why was the transfer? Were you able to transfer specifically to any midwife? Do you have any relationship to anybody in the hospital? Where would you transfer to? In what scenario? Like I know one midwife said, for a baby, I would transfer to such a hospital. It's a few feet away and it's a great hospital for sick babies. Before delivery, a mom might want to be transferred, and they might have connections to Methodist, to Woodhull, and you would want to know, these are good questions to know ahead of time.
You want to ask the midwife, will you come with me if we get transferred? And what kind of role would you then play? Most home birth midwives do not have privileges at hospitals. So what that means is that they can come along as a support person. Now, if they have a relationship with a certain hospital or with a certain doctor or midwife, or they can call and see, oh, well, this is not an emergency transfer, which most home birth transfers are not emergency transfers. They can call and see, if any of the people they have connections with are on shift that night. That's going to make a difference. But usually when the home birth midwife transfers, if she comes along with you, she will then be more of a support person than your provider. But that's a good question to ask altogether. What is your role once we transfer, if that happens?
And if so, would you follow up postpartum? If I was transferred, would you come for a postpartum visit? Will you follow up postpartum phone call? Where does my care end up? Do I end up with the doctor who delivered me, or will you come for a postpartum visit? These are also good questions to ask. And also, for my own delivery, what does postpartum care look like?
What happens if I want to transfer and you don't think it's necessary? It's not medically necessary. I'm exhausted. It's been many, many hours. I want pain relief. Are you going to support me in that? Testing and screening. Most home birth midwives do all the typical testing and screenings that hospital midwives do as well. Again, because in most cases, this is really a relationship where you get to learn more about what this testing is done for, what this medication is given for, what happens if I don't want to do certain testing, or I don't want to take a certain medication. Are you okay with that? What happens, and what would be a scenario where you might say, well, we discussed that we're not going to do, let's say, postpartum Pitocin, but this situation is warranting it. What kind of situations could come up at my birth where you might say, we need to change your birth plan? Why? Postpartum Pitocin is given to help the uterus shrink back and stop the bleeding postpartum.
In standard in the hospital, as you were saying, it's standard in the hospital. If you can refuse. In a home birth, midwives bring it in case you need it. If there's heavy bleeding.
So people can choose not to
You can refuse. You can refuse any care.
You could, but it's very hard.
So that's where you have to choose
your provider wisely.
Provider and your hospital, if that doesn't align with you.
It's also something you can put on your birth plan. When I meet with my private clients, I recommend that they make a birth plan that's very clear.
you're gonna give a nurse an essay to read that's 3 pages long, she's gonna roll her eyes and not read it, right? But if you give her something that's bullet points, and the first paragraph says for mom, and there's 6 or 7 things that are bullet pointed for you, and then you write for baby, and there's 6 or 7 things you want for baby, and it's easy for her to look at, then she'll read it, right? And saying like, I don't want postpartum Pitocin on your list is something that you could put on your list. They will probably talk to you about it, ask you why you don't want it, have a discussion with you about it, but you could refuse it.
I do always tell people that is also part of researching who your provider is going to be. If you're somebody who's going to want to refuse postpartum Pitocin, are you with a provider who will be comfortable with that? Or who's going to push back and say, well, women die in labor, scaring you is a sign actually that you're not with the right provider, because the provider should be giving you pros and cons of choice A and pros and cons of choice B, not just pros of choice A and cons of choice B, which we often see providers do as informed consent, but that's not true informed consent.
Projecting their own personal biases.
Right, and they're discussing it with you, which is much better than just, doing whatever they're doing without even asking you or discussing it with you. It's just that true informed consent means that there's always multiple options, and that all of those options always have pros and cons. And it's up to you as the patient, as the mother, to make that decision for yourself.
You have to just understand that. You also have to remember that a lot of midwives and doctors and people who work in hospitals, for example, they see a lot. They do. They do more births than the home birth midwives. And some of the protocols and policies have been established because of something that they've seen. You can't fault them for it. This is the kind of care that they want to provide. This is the kind of care that they, feel is right for the patient. But everything is up for discussion.
And having a doula at your side, particularly if for whatever reason you're with a provider where you, let's say, liked 80% of what they offer, but not 20% of their offer, but you made that choice for whatever reason, or if you're with a provider that's a group and you just don't know who's going to be there, or you're going to be with a provider who covers 80% of the shift time, but 20% you're just with residents and they might not be there. So those are situations where having a doula, part of what doula helps with is advocacy and making sure that your wishes as much as possible. Obviously, doulas, we don't decide what other people do at your birth, but we can try as much as possible to help you speak up for your needs, plan for that, make your birth plan, and things like that. The more you do in advance is better, and that's why we're here to have that talk.
You have time to say what's the pros and cons of this.
Maybe at the end?
Can I just ask something? It might be a silly question. What's the difference between a midwife and a doula?
It's not a silly question. Okay, nothing's ever a silly question. A midwife is the catcher, and she's the medical provider, and she takes care of the medical part and the emotional part of the mom. The doula is the emotional, physical part, meaning she supports you in labor physically, mentally, emotionally, and also sometimes even through pregnancy and postpartum. The midwife does like I said, the catching. She does the blood pressure, the checking the heart rate. What? The medical part, yeah.
And because when we're talking about home birth midwives specifically, many of the home birth midwives, from what I understand, midwife is originally from a German word. It means to be, with the woman. For those who speak Yiddish, midwife, they're with the woman. So the whole midwifery model is also to be the doula. And sometimes when you hire a midwife or a midwifery group, you can ask that question if hiring a doula is not within your budget, let's say, are you going to come, especially when you're doing, let's say, a home birth, when do you come in labor? Will you also support me? Do you massage? Can you, encourage me and be that person as well? Or do I need to hire someone separately?
Do you think they're both necessary? A doula and a midwife?
That's something you need to explore. You might want to do it for your first and may not want for thereafter, or you might want that for all your births.
Somebody who had kids before but is having their first home birth might want that. Somebody who had a difficult experience in the past might, for the next birth, make sure to have a home birth, doula with her, and some people, who have they already had 2-3 births and they were all 3-hour labors, and, their husband came with them, and, that might be a reason, not to need one. Right. Can your mother come with you? Can your sister come with you? Female support in birth is a very big deal. It is. Why? I don't know. Ask Shifra Pua. I said female support, having a woman with you, and statistically, again, we're going off topic here, but statistically, women who have a female support with them when they give labor have better outcomes. Less C-sections, less epidural use, less postpartum depression, better, positive thoughts and feelings about their birth. So there's value to having somebody there. It doesn't have to be a professional doula. Okay, back to choosing your home birth midwife. Will you ever leave a labor? Why? And what if I asked you to stay anyways? I was once at a birth. It was a very long birth, and it was appropriate for the midwife to leave, and the woman, really begged the midwife to stay, and she did. She did, yes, she did. That also can vary,
That's something.
We'd like to stay. Our goal is always to come and stay, but sometimes if it's been 2 days, we need a little sleep. Sometimes, or go back to our kids.
Only when it's like really not like.
That can vary. That's a great question to ask when you hire your doula. When do you come? Do you carry, we talked about some of these medications, do you carry them with you? Do you have oxygen with you?
Metrogen,
Pitocin.
IVs.
So we didn't really cover birth centers. Birth centers are technically, the way I usually simplify it, is a home birth in somebody else's house. That's basically what it is. It's a place that's set up for birth, so you can be out of your house. Sometimes people with Crown Heights small apartments, that could be a very good choice.
You also have to remember, because you're in somebody else's house, you're abiding by somebody else's rules.
Yeah, they do have usually more rules. And also what we've seen so far in birth centers is that very often, like we have the, sometimes there's more of a turnover with midwives. It's usually groups, not one person that you have a relationship with. And they have stricter rules, like Nechama was saying, about when you get risked out of their care, which,
Stricter than what?
than home birth. Yeah. With home birth, it could very much more depend on the midwife, and there's more of that conversation of like, well, for example, 42 weeks. Most birthing centers, once you reach 42 weeks, you have to give birth at a hospital. At a home birth, that could be more of a conversation on the risks and, where you're at, etc.
What about needing to be induced?
It's a good question. It's a very good question. That's something you want to discuss in the interview with your home birth midwife. You want to ask, will you help me get started at home? How? They might suggest you do acupuncture or start with homeopathy. They might have herbs with them. They might strip your membranes as well. I had a midwife who did that for me the day before I gave birth. That was great.
What does that mean?
As Irit explained, they put their finger inside and they separate the bag from the uterine wall. That's what it means. It feels like a sweep.
It's a little bit more part of childbirth education, but you could look it up probably.
So it's 9:10, so we want to continue.
What if I'm in early labor and it's technically time where you as a home birth midwife wouldn't come yet, but I really want you to come and check in on me. It's been a long, long time, a very long early labor. Are you going to come and, do a heartbeat check and just, check in on me?
And it's important they do, my opinion.
Right. Take this one?
Yeah. Take that one.
Okay, so this is actually very, very important. It applies also in a hospital setting. It's not necessarily home birth midwife specific. If you recommend something and I want to take a different path or make a different choice, what does that conversation look like? And what would the outcome be? The red flag would be, well, I'm the provider, don't you trust me? we want to have a conversation, or scaring you into making the decision that I, as a provider, feel right for you.
Will you run through what needs to be done to set up the birth with me and my husband? Will you explain what to expect? There's some midwives who are very good with that. They go through everything. Set up to cover your bed, to have things to clean the blood stain out of your duvet. What
different
chalks,
supplies.
different supplies that you need. What would you need for what? Garbage bags, paper towels. I can go on and on. This is a lot of fun.
Towels.
Towels, how many towels? How long after birth do you stay? Will you stay later in different scenarios? Do you help with cleanup, take apart the pool, etc.?
I was once at a home birth, and the apartment was very small. You know what are those apartments without a hallway? You walk in and you're in the dining room. It's like this little tiny square, and off of that were 2 tiny bedrooms, and that was it. So it was our first baby, which was fine, but she set up her birth pool in the middle of that little tiny dining room. It basically, you had to walk around to get to the door, like literally like that. And the birth was over, and guess what day of the week it was? It was Shabbos. It was a non-Jewish midwife with a non-Jewish birth assistant. Overall, I will say I have had, and I'm sure Nechama will say the same, very good experiences working with most home birth midwives and respecting things like Shabbos and you're not taking insult, whatever. But this midwife was like, nope, I don't touch the pool. And her assistant was also kind of insulted that she was asked to do things like, I don't know, plug in my phone to charge or whatever. So yeah, those are definitely most home birth midwives that, I would recommend will, within an hour or two of birth, you cannot tell that a birth took place there. And that is from, the standard that I would hold is, part of, home birth midwifery.
You also want to know postpartum visits. How many visits do they come postpartum? Do they come to you? How soon after birth?
What do you want them to do? Or,
For
what would you want them to answer?
So I was actually just thinking about that we're bringing a bunch of questions, but not necessarily giving you exactly.
Right.
So there are,
You said your opinion.
right. So there are some things that are individual, depends on your personal preference. But here's the thing, when you're interviewing a few different midwives, you're going to get, different responses, and that will help you make that, differentiation. One midwife will say, well, I come within, standard is all midwives should come back within 24 to 72 hours to check on you and baby, and the next visit is at 6 weeks. And some might be, well, we do also a 1-week visit, and we do a 3-week visit, and we do a 3-month visit. So there you see that difference right there in the people that you're interviewing. And again, what we said before is you can get, if you're a home birth type person and you're having your first baby and that's what you're going for straight on, it could still be really helpful to educate yourself on what is standard in a hospital model. Not because you have to copy that. There's a lot of things that are done standard in a hospital that are not done standard at home, and it's completely safe to do so. But then it's like, oh, they give an antibiotic eye ointment for the baby. You can go look that up. What is that? Why is it given? What are the pros, pros and cons? Now I can decide for myself at my home birth, do I want that? Do I not want that? So educating yourself on all these things, as well as comparing different providers, will help you figure that out. And when you do call your references, or you can ask the midwife, can you send me some names of references? Or if you have family and friends that have used this provider, so those are some things that you can ask them about as well. Great question. Ask the midwife. Do I have to come to you, or do you come to me for the postpartum visit?
The first visit should be in your house. 24 hours, 72 hours. You just had a baby. You should be in bed or near your bed, and you should be having visits come to you.
But some home birth midwives in the 6-week visit already have, different ways of doing things. Some home birth midwives do all their visits in your house, and some will have an office. And then they come, I think it's very standard that they at least come once to your house to kind of get a feel for what your house is like and, help you with ideas for setup.
What does post-care look like in hospitals? Sorry.
So,
You go to
we actually specifically did not work on, did not focus a lot on postpartum, so we didn't think that we would have the time. But and quickly, every single day that you're in the hospital, you get to see a doctor or midwife from your group. They'll come check on you every day, and then there's nurses around all day long. If you've had a C-section, you'll go for a 2-week visit, and then a 6-week visit. And if you have a regular delivery, a vaginal delivery, you'll go for a 6-week visit after that.
Part of that is also that usually when you're in the hospital, you're there for the first 24 to 48 hours, or 3 days if it's a C-section. So they're covering lots of care there, and then they usually send you to your pediatrician, which home birth midwives typically also do in the first week, postpartum. So that's also kind of like sometimes the roles are a little bit different. And the home birth midwife, for example, in the first 3 days, she's also doing the newborn care, examining the baby, checking that everything's fine. When you're interviewing a group specifically, and this also applies in a hospital, group, you want to ask something like, are all the people in your group, have this same philosophy or the same amount of training? Does everybody know how to place an IV? Midwives that are nurses, for example, even in a hospital, home birth, the midwives and the doctors are not usually placing the one in IV. But if you're having a home birth midwife who in the past was a nurse for, X amount of time, she has a lot of experience in that. Are all the midwives in your group trained in breech delivery? Are they all, great with resuscitation? Is everybody up to date on they should all be. That's really, basic. They should know how to help a baby breathe. That needs a little help in the beginning. And how do you all practice these skills regularly, like we discussed before, so you're well trained if those situations that are uncommon, but do sometimes happen, arrive? Another thing, if you yourself had a specific situation or complication or variation at your birth, at a past birth, or just a medical something, you want to ask your midwife that she's experienced in that, and also what is her plan going to be. Answers such as, oh, it's fine, we're trained in everything, we're good, that's not good enough. I want to hear as the mom that you have experience in this specific thing, and what is the plan? How are you going to, you can't give me standard care, what you do for all your home birth clients, because I have something specific. I want to hear you tell me how you're going to do that. So when you bring that up, red flag would be, not really listening to you. Your concerns or fears are dismissed. Oh, that was a fluke, but it doesn't mean it's going to happen again. That is great. We want to believe that, but we also want a plan in place. So I actually, one of my home births had bleeding that was more heavy, and the midwife did need to give me some medications and apply manual pressure to stop the bleeding. Everything was, she was well trained and everything was under control. But one thing that I think they forgot to do is check my irons afterwards and make sure that I was getting back to my regular strength. And so 3-4 weeks postpartum, I was still feeling so weak where I can only spend like an hour or two out of bed, which is not normal for 3-4 weeks postpartum. And they're like, oh, you should be taking iron. I'm like, thanks for telling me. So it was a very, and when women are physically weak, they're also mentally, emotionally more likely to be weak. And it was a very long, difficult physical and mental, emotional postpartum period for months. So on my next birth, I hired a midwife and I asked her, I'm usually a person who is very holistic minded. I'd rather not take medicine if I don't have to, etc. I don't want interventions at my birth unless there's a real need, but I wanted to hear what she has to say. How are we going to do this better next time? And she said to me, I'm not scared to use medicine. And here's going to be our plan. And it made me a very holistic person, very secure to know that she's very confident to use first Pitocin. We're going to wait, actually that wasn't the order. She said first herbs. If that doesn't work, we'll wait X amount of minutes. I don't even remember how many it was. And then we're going to use Pitocin and we're going to wait X amount of minutes. She had a plan in place. And there's a medicine that, needs to be refrigerated. She's like, from 36 weeks, we keep it in your fridge so that we're not relying on me throwing it into my bag last minute. It made me, and a funny thing is, like when we talk about like, what did you not like about your midwife? People ask me, well, she's a little bit on the forgetful side sometimes. So it made me feel really secure. I'm also extremely forgetful. That's why I have notes here. And, things like that. All my point is everything has to be written down because I forget. So that's okay to be forgetful. How are you being responsible about it? It made me feel very safe that she had a plan in place. What else? A midwife that tells you to do something or not to do something. Oh, you don't want that medicine in your baby, that's recommended or whatever. That's not informed consent. That's you telling me to yes, do it or not to do it without having a conversation and, education. Scare you into doing things or not doing something is definitely red flags. We discussed what true informed consent is, pros and cons on both sides. Another red flag, both hospital and home, you only can bring a doula from this list. The doula doesn't work for the doctor. That's one of the ways that we help women advocate for her themselves, because we don't owe the doctor anything. So they don't get to choose your doula. That's something that you privately hire, and every hospital, you have the right to bring an advocate, to bring a support person. They don't get to say only these. And you might find a home birth midwife also who says, well, only from this list because we work better with them. Find out more about that. That might not be so great. And then very, very important, after your visit, hospital or home, how does this doctor, midwife, home birth midwife, how does this person make me feel? How do I feel about my pregnancy? How do I feel about my upcoming birth after I walked out of this conversation? Do my values align? Do I feel comfortable in their presence? Do I feel safe? It's not a time to ignore these things, and I'll put in a little plug for mothers, sisters. My mother has to come to your birth. No, she doesn't. You want people in the room with you that you really feel 100% safe with, because when we don't, we sometimes are behaving differently or changing things in the way we would want to do, and birth is not a brain-on time. It's a time where the hormones need to be able to flow comfortably, and sometimes that, mental, emotional piece can have actual physical outcomes for mother and baby. So
nobody has to know you're in labor either. If your mother-in-law is going to be insulted if she doesn't know, you can tell her just about when you're about to push.
Or not at all.
Or
it's
not
your
at all.
choice.
Right.
I'm not saying that mothers are bad in the labor room, by the way. We've had some, of course, all of us, some great experience with some very supportive mothers. And mothers can also work alongside a doula. Sometimes a mother is there for emotional support, but she doesn't know actually what to do. So you have both of that. What have they answered that makes me feel at ease? What have they said that I'm not so comfortable with? Don't just leave it. This is a home birth midwife is a very personal relationship, and try having another conversation and see how that goes. Can you come to a better resolve? What is my gut telling me?
Even if it's your first birth, trust your gut. I always tell clients, even when it comes down to your water breaking, I always find mothers know. Do you ever find, I think my water's about to break? And it does. Or I feel the baby descending. They know. It doesn't have to be 3, 4, 5, it's your first, it's in you.
And it's also just know that it's never too late to switch. Sometimes it's hard to navigate that and to find an alternate best solution, but if the situation is such that you don't feel safe with someone. I was once at a home birth, and this midwife, I was laboring with this woman beautifully. I was supporting her. We were in our house. The time for the midwife came, and the midwife came in. She started opening up her tools and making a ton of noise, and she just took up way too much space in the room. And the birthing woman made it clear that she wasn't comfortable with having her. So the midwife went downstairs to the couch, never came back up, and eventually came up, and I don't know if she started talking about transferring to the hospital, or she ended up or leaving, or I don't remember what it was exactly, but she had her balance between being hands-on and hands-off was a tad off. And then what ended up happening is when this woman was actually in labor, and the midwife needed to come to check the baby's heart rate, and the woman like kind of shifted to the side, or, maybe it just wasn't the right moment. Give her a little space and come back a little later. And I think it was maybe pushing time. During pushing time, you need to check a little bit more often because there's sometimes more pressure on the baby. And the midwife was like, well, she doesn't want me to check. Again, there was like a little bit of like a,
Attitude.
yeah, there was an attitude, but there was also, it's a fine line between being hands off and being responsible. Yeah, that is definitely part of, sometimes our doula's role is when the woman is not being listened to, or when the birthing woman is, at a point where she's able to speak, but you already discussed, because we have a relationship with this woman, with our clients, so we know what their preferences are, we can speak on their behalf. There's no provider is perfect, but if the fit is not good, that could lead sometimes to poor decision making. So we want to definitely avoid that. You want to be with someone that you trust, that you have good communication with, and those things, as well as her skill and speed, are really important. So we want to be prepared. That's our talk for tonight. Any questions? Sure.
How come you didn't? How come you skipped over the postpartum psychosis and the other stuff? Didn't read through all the words, all the details? Oh,
and it's more educational. It's not so much, right? It's not so much on the topic of choosing a provider.
It's not on the topic of tonight. I just been told that I do about birth. I throw it in because I think it's important for people to be aware and to read it.
no, it's really important. That's what I understand what you're doing. Thank you so much.
Oh.
So it's standard in New York, breaking down the hemorrhage levels. That is why it's to stop the hemorrhage, to stop people from bleeding. It's a standard of care in New York, and a lot of hospitals are working different protocols to try to bring down the levels of hemorrhage post-birth. Yeah, with other medications and different things. Some people are using Chassidus, some people are giving another medication called CXA, some people are using... not so good. No, just different.
Usually Pitocin is the first thing that's given.
Right. Why did they try to find other ways?
Because some people are hemorrhaging, and sometimes they're doing trials. For a while in Methodist Hospital, we were doing a side effect trial. Every single patient who agreed to the trial, we're doing a trial. Pitocin and side effect, which consents to the trial, was helping us bring down the hemorrhage levels. It's a choice. It's a choice. Some people who have had previous hemorrhage, yeah, I'll do anything to stop me from hemorrhaging. I'll give it a try. And some people, yes.
Sometimes doubling up the medication is what's needed.
Right, and sometimes, it also really depends on the birth. What happened at that birth. Sometimes your hemorrhaging depends on, like, if birth was super quick, or the birth was super long, and you got a lot of Pitocin. All these different things can affect what's
what number baby?
So for
what number baby.
some people will have nothing.
Yes, both in hospital and at home. Because again, this is the majority of people giving birth are at home are trusting that our bodies are designed to do their job, and that we only give a medication or take a medication. Again, it's a personal preference. If somebody's giving birth at home and they want vaginal exams throughout their labor, that's something that they can, discuss with their midwife or before hiring, if that's the type of, care that they want. Again, Pitocin, you want standard Pitocin, whether you're bleeding heavily or not. That's definitely something you can take. Most people giving birth at home don't want unnecessary medication.
But the midwife leaves once the baby's born.
No, that wasn't the questions also. How long do you stay? What's common? A couple hours.
Like 3, I would even say 3 to 4 hours. Sometimes they'll stay.
So if someone's not getting Pitocin, how soon might
1 to 2
they all of
hours
a sudden
to do
start
those things,
bleeding?
unless something else is going on.
So
It could be 24 hours bleeding, 12 hours.
it could happen.
And then
So it's interesting. We were actually discussing it. There is a certain midwifery group. They have the women keep Cytotec on hand just in case. Educating on what the uterus should be feeling like postpartum, and what normal bleeding is and not normal bleeding. Of course, you always have the option of calling Hatzala, but in the majority of cases, again, this is a little bit more on topic on like home versus hospital birth, but a non-intervention birth is less likely to have a postpartum hemorrhage. And so if the midwife has assessed everything and the uterus is nice and firm on check 1, 2, and 3, let's say, I don't know what she's doing, and she's checking the bleeding, she took her to the bathroom. The midwife is there with you the whole time when she's there, and she should be, and that's maybe something to discuss. And not like in a hospital birth, the midwife after let's say stitching needs to be done, placenta's out, everything's done, she leaves the room, the nurse now takes over and does cleaning the woman up, helping her go to the bathroom, things like that, helping with nursing. So, here it's a one-man show, which allows her to get a whole assessment. And in the large majority of cases, in a non-interventive birth, where in the first 3-4 hours there was no hemorrhage, it usually remains like that.
Most home birth clients know what their uterus should feel like, because in the hospital, they automatically come in and say, I'm going to feel your belly again, and they lift up the sheet and they rub your belly nice and firm. At home, the midwife will rub it up and say, look, feel this. This is what it should feel like. So to let you know what your body should feel like. So you'll notice as well. So it's
I will also say that when I first became a doula, it wasn't standard to give Pitocin, a standard. It was given, right? It was given, on a individual basis.
You also have to have an IV to be able to give it. Not everybody consents to an IV, and not everybody has time for an IV. So you don't think sometimes offer you an injection of Pitocin. Sometimes, you don't get anything.
And at home,
Recovery's
usually,
not getting longer.
huh?
It's not making the recovery longer.
I don't think there's a
no.
difference.
I've actually heard some moms say it's more uncomfortable taking Pitocin. But if you need it.
The only thing that we really want to consider is if you have like a history of hemorrhaging, or you have a bleeding disorder, or there's like a red flag in your personal history, that's something to think about. You also don't want to put yourself in danger. I can only speak from a hospital perspective, right? I don't know what a home birth midwife would do with somebody that they might risk out some home birth midwife if they've got a bleed. I don't know. They might use herbs. I don't know. But for a hospital birth, if you know that you had a hemorrhage at one birth, that might even be your focus. I want Pitocin, I want CXA, I want that estrogen, I want 3 medications to stop me bleeding because I don't want to go through that.
Right. Or if you are still doing a home birth and you have had a hemorrhage or a heavy bleed in the past, the midwife maybe needs to stay longer postpartum. I've had definitely, midwives tell me that they slept on the couch for the night. It's holistic care, and she wants to be there for the woman and not have to transfer her, but she needs to keep an extra eye because this baby was just borderline with the breathing, need a little bit help, and still looking a little that way or the other way. She's going to stay 6 hours.
When is usually a hemorrhage expected? Is there a time frame?
Not necessarily.
But you said within the first
Usually,
24 hours,
right. Usually it's in the first few hours, but that it does happen that there are surprises. That's why we want skilled people at your birth. We want to be able to. But if there's a surprise the next day, please pick up the phone, call your midwife, and possibly call it.
Is there something to do besides?
This is a very big question, and it's so individual. It could be if someone has a bleeding disorder.
I'm saying someone that doesn't know of any.
Are you asking about preventing hemorrhage?
Yeah. At home or in the hospital? Anyway.
I mean, she can take herbs from the get-go, taking Pitocin automatically right after the birth, whether there is a sign of extra bleeding or not. Breastfeeding is good to help the uterus contract, and also knowing how to, the midwife will tell you, like, if you feel that the uterus is feeling like this, you want to kind of give yourself that, stimulating rub to get the uterus to contract again, and call the midwife.
And please rest.
What?
Resting.
Rest, yes.
They just tell you the risks. Remember, like, choice. I didn't know it was possible.
Everything's a choice.
Everything is a choice, and that's why it's so important to choose a provider who's on the same lines as you.
you want to choose somebody who will let you choose if you want.
I guess I also have to be informed myself, like,
Having
What
a
I
doula
know.
helps. Having a doula helps. Being educated helps for sure.
Reading books, taking classes, and also forgiving ourselves for the things we didn't know. Like
I also don't,
you can't know everything
don't
ever.
wanna only read about scary things.
Right. You don't have to. And
There's
that's
different
why-
types of education also.
Right. And that's also another reason why I love this book called The Natural Hospital Birth. It's like, she talks about how to navigate that with hospitals.
Who's it by?
I don't remember offhand, I have to look it up. And one of the things that I learned the most from that book was always ask the whole time. Time, what? That sounds right, yeah. In hospitals, time is not the same as time in real life, right? An hour means 2 hours, 30 minutes means 20 minutes, or 2 hours. Like, hospitals start get busy with things happen, yeah. And it's, just the same way that the doctor says, I'm coming back at 8 o'clock and comes back at 9 o'clock. You could also say that, I want to break your order. You could say, please have an hour to think about it. You don't even have to discuss anything else. They have to respect your choice to do that. You're allowed time. Unless it's an emergency, you're allowed time. And that's the time where you could speak to your doula, you could pick the phone up to somebody, you could educate yourself then, even if you need to. One of the things I say when I teach childbirth classes is that, you want to be as informed as you can to be able to make a decision in the moment. So whether that's reading books or taking classes or speaking to friends or doing whatever you want, there's lots of education out there. And we're all here to help. That's what community is about.
Just really question mentioned a little bit about birth center. Just kind of said that it's kind of like giving birth. I know there's not really birthing here, but there's one opening or just open. Is it really just that it's giving birth in a different space? Because I guess my impression was that it is more intervention, not as much as hospital, but like.
That could depend on who are the midwives that are working there. Again, are they more on the medical side of things, or are they more on the holistic side of things? In terms of like equipment, like some people think that birthing centers are like in between in terms of safety because they have more. They don't. Some usually it also depends where you're giving birth, different state regulations in terms of like how far a birthing center is allowed to be from the hospital. But in general, it is a place that's set up for a out of hospital birth.
Where do you, there's still like a list of.
Some birth centers have like OBGYN.
They don't have them there. They have to be backed by one. They have to be regulated by one. But they're not part of the staff.
They don't have to.
OBGYN? I don't think they come to births, but that's a great question to ask.
But it's run by midwives.
Yeah.
They're the director of the center and whatnot, but I don't think that they're there on site.
They may just check over their records once in a while.
Right, or they're used for consulting with in different situations. They might be the final, they probably have like, let's say, rules about what is considered high risk, because somebody who's high risk cannot give birth out of a hospital. Obviously, that's a very general term. If somebody has gestational diabetes, is that out, risk you out, et cetera, et cetera. If something is maybe, let's say, borderline, they might be the one to make that final decision. But it could vary from birth center to birth center.
If you want, I don't know what you're thinking. I mean, I can offer but if you are going to have a hospital birth, we want some time.
They did an open house. Yeah.
And I was kind of like, what hospital is it?
Right. So, we know the group who's opening it. We know that they themselves, for example, may not all be allowed to work at the birth center because of, against distance rules. They have to live at a certain distance from the birth center.